Hi, I'm Dr. James C. Wittig. I'm an orthopedic oncologist and sarcoma surgeon in the New York metro area. And this is part B of our unknown musculoskeletal tumor cases, in which this gives you a way of testing yourself and reviewing and preparing for your boards. We're going to discuss 10 cases today, cases 11 through 20. For cases 1 through 10, please look to Part A. There will be additional parts that will be posted on YouTube also as part of our unknown cases, and please review these also. I think they will be very helpful for any of the tests or boards that you'll be taking. For more information on musculoskeletal tumors, please visit my website at www.tumorsurgery.org. Case 11 is a fairly active 62-year-old male who complained of right hip pain. After imaging, a lytic lesion was discovered in his right proximal femur. Physically, the mass was palpable. He had no recall of an accident or trauma, but he noticed pain after walking on the treadmill. The pain has increased over a span of 2 months. MR showed 2 lesions, one in the subtrochanteric area and one in his intertrochanteric area. This is the plain X-ray showing a lytic lesion in his right proximal femur. There's perhaps a crack that developed in the bone. It looks somewhat central on the AP and the lateral views, but there's this cortical thickening around the tumor, which is very worrisome. And then up in this location, you see a lesion with mineralization within it. Okay, it looks like punctate or ringing out are calcifications that would be indicative of a cartilage tumor. So the question are these two connected in some way, or are they separate entities? Given his age, immediately you would think that this is either a Mets myeloma or lymphoma. However, the next most common malignancy, which is a primary malignancy of bone, would be a chondrosarcoma, followed by a malignant fibrous histiocytoma of bone, and followed by fibrosarcoma of bone. It's also plausible that this can be an infection. Okay, that should almost always be within your differential diagnosis. And eosinophilic granuloma can have a similar appearance. Now, given the fact that there's what looks to be a cartilage tumor here, I'd be highly suspicious if this is some form of a cartilage type of tumor, or perhaps an area of the cartilage tumor that's undergone dedifferentiation or has turned into a high-grade area. We know that high-grade or grade 2 to 3 cartilage tumors do tend to cause this periosteal response or cortical thickening in the bone that it arises from, or can cause that. It could also spread extraosseously. But on this X-ray, these two X-rays, I don't see any mineralization in this lytic area itself. So, say this was a cartilage tumor and this was a dedifferentiated chondrosarcoma, perhaps this patient had multiple enchondromas, which does place him at a higher risk of having develop a chondrosarcoma. Another possibility is this could be a met to an enchondroma or an area of an enchondroma. So certainly different possibilities. Okay, let's see any additional images. Again, just another AP X-ray, not giving much more information. MRI demonstrates the 2 lesions in the femur, which appear to be separate from each other. T2 or a star-weighted MRI, 2 lesions in the proximal femur which seem to be separated from each other. Doesn't give much more information than what we deciphered on the X-ray, except that these 2 lesions don't seem to be connected, at least physically connected. This is the more proximal lesion, which looks like a typical enchondroma on the T1 weighted image. They grow in a lobular manner, and on a T1 weighted image have similar signal characteristics as muscle. This is a T2 weighted image of the more distal lesion. And you can see where this tumor has actually breached the cortex. Its very high signal has breached the cortex, which gives it a very concerning or aggressive appearance. A biopsy was performed, and the biopsy shows, this is one area of the biopsy, which shows a cartilaginous tumor. There's a relatively low-grade cartilaginous tumor. There's cells that are in lacunae, and the matrix in between the individual cells has a ground glass appearance similar to hyaline cartilage. It's relatively low cellularity. Down here, there may be some endochondral ossification that's gone on, or actually this may be bony entrapment of pre-existing trabeculae, giving this a malignant appearance. When cartilage entraps bone or encircles a trabeculae, then it's considered malignant, because benign cartilage comes up to and abuts normal bone, but it does not entrap it or encircle around it. This is another area where you see here the low-grade cartilaginous tumor, and then an abrupt transition to what looks to be a high-grade spindle cell tumor. And this is very characteristic of a dedifferentiated chondrosarcoma, where you have this low-grade cartilaginous component and a high-grade spindle cell component. High power view showing you the abrupt transition between the cartilaginous component, where you have these cells in lacunae and this ground glass appearing matrix between all the individual cells, and then an abrupt zone of transition between the cartilaginous component and the high-grade spindle cell component. The most common high-grade spindle cell components of a dedifferentiated chondrosarcoma include MFH or UPS, undifferentiated pleomorphic sarcoma, osteosarcoma, and fibrosarcoma. This looks like an undifferentiated pleomorphic sarcoma. There's hyperchromasia, pleomorphism, hypercellularity, mitotic figures such as this, and these mitotic figures. There's several mitotic figures in this high power field. Very rapidly dividing tumor. I don't see any osteoid production, hence hence the dedifferentiated component is probably an undifferentiated pleomorphic sarcoma and not an osteosarcoma. In either case, it falls into the category of a dedifferentiated chondrosarcoma. So the final diagnosis is a dedifferentiated chondrosarcoma. A dedifferentiated chondrosarcoma is a very aggressive tumor. 95% of patients die within 2 years of the diagnosis, despite surgery, despite chemotherapy, despite radiation. It's a very aggressive tumor with a very low survival rate, and nobody really has quite figured out why it's so aggressive. But dedifferentiated chondrosarcoma consists of a low-grade cartilaginous type of malignancy with a high-grade spindle cell sarcoma. And the most common spindle cell sarcomas that develop from the low-grade chondrosarcoma is an MFH or an undifferentiated pleomorphic sarcoma, a osteosarcoma, and fibrosarcoma. And generally speaking, these entities or these high-grade spindle cell components behave more aggressively than if they were to occur solely on their own arising from bone without being part of a dedifferentiated chondrosarcoma. Dedifferentiated chondrosarcomas usually arise from the proximal femur, the pelvis, the ribs, or from the undersurface of the scapula, and they may be as a result of secondary chondrosarcomas, namely those chondrosarcomas, low-grade chondrosarcomas arising from an osteochondroma or for pre-existing enchondroma, particularly in the setting of multiple hereditary exostoses and multiple enchondromas or enchondromatosis. But again, a very aggressive tumor. Generally speaking, it's treated with a wide or radical resection and reconstruction, if possible. Most instances it's possible. Amputation is reserved for unresectable tumors. chemotherapy is extremely controversial in the treatment of any type of chondrosarcoma, and we don't really know if it is very effective in treating this type of tumor. But medical oncologists may prescribe it, but generally speaking, for your boards or your OITE, probably the answer would be wide resection and reconstruction, and I don't think that they will ask you about chemotherapy because it's very controversial. Okay, this is case number 12. Case number 12 is a 38-year-old woman who presented with a small, painless, mobile, non-tender mass in her right anterior shoulder that was first noticed 3 months prior. The mass did not enlarge. She denied pain, fever, chills, numbness, tingling, and weakness. MRI showed a mass in the subdeltoid bursa. The mass was removed and analyzed. This is coronal T2 weighted fat-sat MRI, which demonstrates a tumor in the subdeltoid space or associated with the bursa. The mass has high and low signal areas. Again, the T2 weighted MRI showing you the mass in the subdeltoid bursa, relatively nonspecific. This is a biopsy specimen which shows giant cells admixed with these other spindle type cells and fibrous type tissue. And then over here on this specimen you see foamy histiocytes, which is cholesterol-laden macrophages. When you see cholesterol-laden macrophages, giant cells, and cells that look like histiocytes or spindle cells over here, that's very suggestive of pigmented villonodular synovitis. And if it was an isolated mass like that, you would think that this is a nodular PVNS or nodular pigmented villonodular synovitis. Different than the PVNS that I showed in Part A, our first case in Part A, which was a diffuse PVNS, which was intra-articular, resulted in a huge joint effusion. But remember, PVNS can occur arise from synovium, and it could be the synovial lining of a joint, synovial lining of a bursa, or synovial lining of a tendon. When it occurs around a tendon, it's usually called giant cell tumor of tendon sheath. Now, the last important differentiating factor that we would look for to diagnose this as PVNS is the presence of hemosiderin. And this is a great example of showing you the hemosiderin in the area. They look like fine rusty granules, which occurs from blood deposition. Okay, so the final diagnosis for this is nodular PVNS, and it's treated with excision, marginal excision. That would be not a radical type excision or a wide excision, and the local recurrence rate is very low, probably approaching close to 0%. Case 13 is a 40-year-old female with a painful, huge mass in her left posterior thigh. The patient stated that she noted the mass perhaps 5 to 10 years prior, but she was told to have a muscle pull, and she felt that it was getting progressively larger, that is. And she also had some arthritis in her knee, or felt like that's where possibly the pain was coming from. On this x-ray, you see a very large mass. This is an AP view, so you cannot determine if the mass is coming from the center of the bone or the surface of the bone. But you see these fluffy cloud-like densities, which are indicative of bone formation. So this is a bone-forming tumor. Okay, should it instantaneously go in that category of a bone-forming tumor or an ossifying tumor? This is an AP and a lateral x-ray. Okay. Again, you see the fluffy calcifications, and you see that this tumor is present in the soft tissues. It's not really arising from the surface of the bone or from um, the medullary canal. It's really a soft tissue mass. It's somewhat irregularly shaped, and you have these fluffy cloud white like densities. MRI was not very helpful except showing the dimensions of the mass. Mineralized tissue generally looks low signal on T1 and T2 weighted images. This is a CAT scan that shows that there's no underlying bone involvement. This does not appear to be arising from the bone. Again, you can see the heavy mineralization within the mass. This is showing you the histology, and you see a pleomorphic spindle cell sarcoma that's producing woven bone. So here is the osteoid or the woven bone production, lace-like in between all these cells. The cells are different sizes and shape. There's pleomorphism, there's hyperchromatism, there's probably mitotic figures. Again, this is showing you a high power view. You see a high-grade spindle cell sarcoma producing immature woven bone, which is all this lace-like pink staining material in between the cells. It's not forming any trabeculae of bone. So putting that together, you have a large soft tissue mass on x-rays producing bone. It's greater than 5 centimeters. It's deep in the soft tissues. And then histologically, you have a bizarre or what appears to be a high-grade malignancy producing bone. You do not see any zonal phenomenon on the radiographs. There's no, it's not trying to recapitulate a normal bone such as heterotopic ossification or myositis ossificans would. So one would immediately call this a soft tissue osteosarcoma. So that's the diagnosis, soft tissue osteosarcomas. Now granted, soft tissue osteosarcomas are also called extraskeletal osteosarcomas, are rare tumors. Osteosarcomas more commonly arise from bone than in the soft tissues, but you can have soft tissue sarcomas that produce bone, and they're called an osteosarcoma of the soft tissues. They're treated like an adult type of soft tissue sarcoma, and which would consist of radical resection whenever feasible, in most instances a limb-sparing surgery as opposed to an amputation, and radiation. Okay. They may also be treated with chemotherapy, but chemotherapy again would be controversial because technically this is treated like a high-grade soft tissue sarcoma. This is case number 14. Okay, this is a 36-year-old female who complains of a throbbing pain in her left calf that radiates distally. This is the MRI, and you see here there's a T1 weighted MRI. Fat is bright on the T1 weighted image, and you see in this location there's an intermuscular mass that has similar signal characteristics as muscle, and it seems to be arising in the fatty tissue in the area of the vicinity of the neurovascular structures, and there's almost a split fat sign around it. It's well circumscribed in the fat and encircles it. Okay, throbbing pain is something to take notice of. Most sarcomas or most malignant soft tissue tumors are not painful. It's counterintuitive. They're a cancer, but they're not painful. Pain is usually indicative of a benign type of tumor, and particularly throbbing pain or something that is tender to palpation where you experience radiating pain could be indicative of a specific entity such as a schwannoma. Schwannomas grow intramuscularly and usually grow in the vicinity of the neurovascular structures and usually surrounded by fat. This is a T1 and T2 weighted MRI image. Schwannomas typically have an appearance similar to what's called a target sign. So on the T2 weighted image, you usually get peripherally myxoid type of tissue, histologically, which shows a high signal, and then more centrally, the cellular areas, which usually show up as a dark signal. If you look at it longitudinally, kind of longitudinal plane, you may see a nerve entering and exiting an oblong-shaped mass. Here's the mass in the calf. Again, perhaps you see a nerve coming down to it and perhaps exiting it. This is showing you the low and intermediate power histology from the specimen, and what you see here is a biphasic tumor. There's two different areas that you can see. You can see this more solid cellular area and this more loose or myxoidy type area. And you see how the nuclei here are arranged in or palisading and arranged in a palisading type manner reminiscent of nerve, and these are referred to as verroque bodies. Okay, and these this is very characteristic, this histology, of a schwannoma or a benign peripheral nerve sheath tumor, where you have the Antony A areas, which are the more cellular areas with the nuclear palisading, and the Antony B areas, which are the more myxoid areas. And more loosely arranged areas. So here's your Antony B and Antony A areas. Here's a more high power view of your Antony A, or the verroque bodies. On an MRI, the verroque bodies, or the more cellular areas, show up as the dark areas on the T2 weighted image, and the myxoid areas, because they hold on to fluid, show up as the brighter areas. And in a schwannoma, there's a tendency for these verroque bodies, or the cellular areas, to be organized more toward the center, which shows up as a classic target sign on the MRI. And this looks much different than a malignant peripheral nerve sheath tumor, where there'd be hemorrhage, necrosis, mitotic figures, hypercellularity, much different. Okay, and then this is again showing you the MRI and the pathology sample. You see this very well circumscribed mass. This is a T2 weighted image. There's more high signal around the periphery and darker signal in the center, which correlates with the Antony B area being organized more around the periphery and the Antony A area being organized more in the center, which you can see here, the Antony B area over here, which is the myxoid area, being organized around the periphery, and the Antony A area with the palisading and the verroque bodies being organized more toward the center of the specimen. The final diagnosis here is schwannoma. A schwannoma is a benign peripheral nerve sheath tumor. It comes from the nerve sheath, or the Schwann cells in the nerve sheath, and it displaces the fascicles to the periphery of the mass. It does not involve the fascicles. It can be removed by opening the nerve sheath, and a marginal excision is performed, leaving the nerve and nerve fascicles intact. Only if it was to be a malignant peripheral nerve sheath tumor would the entire nerve be removed. Patients with neurofibromatosis develop schwannomas and neurofibromas. Neurofibromas usually occur cutaneously, usually are not painful, and they usually interdigitate amongst the fascicles, so they can't be removed unless the nerve is removed. Hence, they're usually just observed. Patients with neurofibromatosis can also develop malignant peripheral nerve sheath tumors. Most malignant peripheral nerve sheath tumors are related to an underlying diagnosis of neurofibromatosis, although not all of them. And if a malignant peripheral nerve sheath tumor were to occur, a radical resection and radiation would be performed. The entire nerve would be removed to its origin, practically, because these malignancies can travel within the nerve sheath. However, schwannoma is benign. It's removed via marginal excision, leaving the nerve intact. They are painful to touch, or usually painful to touch. A Tinel sign is elicited when it's palpated, and they have a very good prognosis with virtually a 0% local recurrence rate after removal. Case 15 is a 47-year-old male with a painless growing mass in the right knee for the last year. So he's 47, he's an adult, and it's painless. This is a T2 weighted MRI image, and you see a mass that is mostly it shows high signal intensity, but there is an area of lower signal intensity which may be indicative of necrosis or hemorrhage. But it's mostly high signal. It's a large mass, heterogeneous, deep to the fascia, and it looks like it's located intermuscularly between the muscles. So one would think that this is possibly a malignancy, or probably a malignancy, given its size and the heterogeneous nature and the deep to the fascia. And being that it's intramuscular, one may think that it's more likely to be a fatty type tumor, or a tumor of fatty origin. Again, different MR images showing you the heterogeneous nature of the tumor, large and heterogeneous. It's adjacent to the knee, but in the deep compartment. This is what the biopsy showed. And if you look at this, you see these circular areas, which are lipoblasts. You should recognize this immediately as a lipoblast with a bizarre nucleus in the middle. A normal appearing fat cell or adult mature fat cell has a peripherally displaced nucleus, which usually looks like a little slit up against the cell membrane. These nuclei are projecting into the middle of the vacuoles. The vacuoles are different sizes and shapes, which are all suggestive of malignancy. Then you have this myxoid tissue surrounding it. And it's very hypercellular. You can see here in this low power view how hypercellular it is. So you put these two together, you have a fatty tumor, a tumor of fatty origin, mixed with myxoid tissue. It's a myxoid liposarcoma. And here's the example of myxoid tissue mixed with lipoblasts. And myxoid liposarcomas can have sort of these staghorn vessels throughout them that look like antlers. Okay, very characteristic of a myxoid liposarcoma. Again, it has a T1216 translocation. There could be areas of it that look like a round cell liposarcoma. When the round cell component exceeds 20%, that neoplasm technically will behave more aggressively and will be considered a round cell liposarcoma with a higher metastatic potential. The treatment for this would be wide surgical resection and radiation. Chemotherapy is controversial in the treatment of it. And the final diagnosis is myxoid liposarcoma. Case 16. This is a 35-year-old female. She had slight pain in the right thigh with exercise for the last 3 months, but was not painful at rest. A biopsy was performed. The sample stained positively for vimentin and diffusely positive for actin. Again, the fact that it stains positive for actin should make you think along the lines of smooth muscle differentiation. You see a heterogeneous tumor here located deep to the fascia, and it's large. Okay, this could be any type of sarcoma, a type of liposarcoma, an MFH, a synovial sarcoma, leiomyosarcoma, rhabdomyosarcoma. All the types of high-grade soft tissue sarcomas can have a similar appearance to this. Again, T1 and T2 weighted images, a large heterogeneous mass deep to the fascia, probably arising intramuscularly from the hamstring muscles. Again, MRI showing you heterogeneous mass, nothing very specific. And this is showing you the histology here. And what you see here is a spindle cell sarcoma. And realistically, this could be any spindle cell sarcoma without knowing what this tumor stains positively for. All spindle cell sarcomas will stain positive for vimentin. Now, the cells are various shapes and sizes. There is a swirling pattern to it. It does have an appearance similar to MFH, except that there are these cells here, with these strange nuclei that you see periodically scattered throughout here. And it seems that these nuclei have curled up and caused almost like a corkscrew appearance from the contractile elements within them. And these are characteristic of a leiomyosarcoma, or a smooth muscle tumor. Leiomyosarcomas stain heavily positive for actin. They may stain slightly positive for desmin, but certainly not as heavily positive for desmin as a rhabdomyosarcoma. So putting this all together with the diffuse staining for actin and vimentin, you would call this a leiomyosarcoma. And again, it could have any sort of radiological appearance. They're one of the more common sarcomas to develop from the pelvis area. They can also develop from the GI tract, which is another common area. And when they occur in the extremity, the treatment for them is wide surgical resection and radiation. Amputation is reserved for unresectable tumors, and chemotherapy may be indicated, although is probably controversial. So don't answer chemotherapy for your boards. Okay, but the standard of treatment is wide surgical resection and radiation. Again, just showing you a low power view of it, which just shows you a hypercellular spindle cell sarcoma. And again, a high power view showing you these corkscrew nuclei, which are very characteristic. See, these nuclei are twisted, and they from the contractile elements, very characteristic of a leiomyosarcoma. Again, that's the final diagnosis. Again, usually occurs in the adult population greater than the age of 50, and can also arise from the GI tract and also from the uterus or the genitourinary tract, which are the most common sites. Again, treatment is surgical resection, wide surgical resection, or radical resection, and radiation. Okay, this is case number 17. This is a 60-year-old male with an enlarging mass and pain in the right foot. Okay, and you see here on the MRI a mass in the area of the heel. This T1 weighted image has similar characteristics as muscle. This is the T1 weighted image and the T2 weighted image. The mass appears to be confined to the subcutaneous tissues. It's not eating into the bone or eroding into the bone, and it's somewhat heterogeneous on the T2 weighted image. Certainly these characteristics are non-specific. Again, heterogeneous, and maybe spans out in this direction over here, somewhat irregularly shaped. This is showing you the histology after the biopsy, low power view. You see a tumor that's extremely hypercellular, okay, indicating that it's probably a malignancy. What's the most common soft tissue sarcoma of the foot? Synovial sarcoma is the most common soft tissue sarcoma of the foot and ankle. Does that mean that this is a synovial sarcoma? Not necessarily. There are other types of sarcomas that can also occur in the foot and ankle. And looking at this, you just see a spindle cell sarcoma in this area. Nothing in particular that stands out about this. Cigar-shaped nuclei, and nothing in particular about the cells. It's very hypercellular. There's some pleomorphism and hyperchromatic nuclei, but nothing really specific about this. And again, this is again a spindle cell sarcoma, not otherwise specified. The cells here may give you a clue as to what it is, but there were stains on this specimen which stained positive for HMB45, which is a melanin marker or melanocyte marker, and putting that together with the histology, this was called a clear cell sarcoma. Clear cell sarcomas are relatively rare types of sarcomas. The foot and ankle, in particular area of the tendons around the foot and ankle, and the elbow area seem to be common locations for clear cell sarcomas to occur, and they're treated like any other type of sarcoma. They are treated with wide resection and radiation, amputation whenever a wide resection is not feasible. Chemotherapy is very controversial, and clear cell sarcoma is also called melanoma of soft parts because it stains positively for melanoma markers. It's not treated like a melanoma, but it does stain positively for melanoma markers, like melanin and HMB45. These are specific markers for it. This is case number 18. This is a 52-year-old female who had mild pain and enlarging mass in the left thigh. She demonstrated fever and weight loss over the last month. She thought that she noticed the mass first develop about 5 years ago and saw her doctor for it, who stated that the mass was just a muscle strain or a knot in her muscle. This is showing you the plain radiograph of her left femur, and you see a large mass probably arising from the femur. We don't know if it's arising from the surface or from the soft tissues, and the mass is very heavily mineralized. The mineralization takes a fluffy cloud-like appearance, which is more consistent with ossification or bone production. So this is a bone-producing neoplasm, and immediately a large tumor like this arising from the femur, one should think of an osteosarcoma, which is the most common bone-producing malignancy of bone. Okay. Given the fact that this is a 52-year-old female, conventional osteosarcomas are somewhat unusual in this age group. They usually occur in the 10 to 20 age group. This is occurring in someone who's above the age of 40. Certainly plausible to be a conventional osteosarcoma, but parosteal osteosarcomas, which are more low-grade in nature, may be present and growing for a prolonged period of time and grow slowly, tend to occur in the above 20 age group. This is showing you the AP and the lateral again, and it looks as though this tumor is probably arising from the surface of the bone. It's somewhat cauliflower-like, and it has this cleft at the periphery. These clefts are usually consistent with a parosteal osteosarcoma. It almost grows like a mushroom or like a cauliflower off the surface of the bone and develops a cleft between this big mass and the actual undersurface of the bone. Parosteal osteosarcomas arise from the outer layer of the periosteum and compress the periosteum up against the bone. It can actually invade into the bone. It usually requires a prolonged period of time to do that, but it's certainly a possibility. And when they're present for prolonged periods of time, they can turn from a low-grade to a high-grade type of tumor and can even undergo dedifferentiation. A periosteal osteosarcoma arises from the inner layer of the periosteum and elevates the periosteum and will give a periosteal reaction. It's also more of a cartilaginous type of tumor, meaning that it has a lot of cartilage within it, although it's considered an osteosarcoma. Sarcomas or osteosarcomas can have different types of tissues within them, even a conventional osteosarcoma, but it's producing bone and is primarily a spindle cell tumor. This is a CAT scan showing you that this tumor is arising from the surface of the bone. It's very heavily mineralized. And this is the histology, and you see here a spindle cell tumor with what looks like fibrous type tissue in between it, cigar-shaped nuclei. The nuclei are relatively bland looking, but they are somewhat large and atypical, and then bone production. And you see here where the bone production takes on almost a trabecular type of appearance with interconnecting areas, and then fibrous type tissue, which is in the center of the bone, and then with bone production. So this, putting it together with the radiograph, so we think that this is probably a parosteal osteosarcoma. Again, showing you different samples. Tissue that almost looks like fibroblastic type tissue, because technically a Parosteal Osteosarcoma is a fibroblastic tumor that's producing bone. And here you see your bony spicules. Again, fibroblastic type tumor producing bony spicules, low grade in nature. Again, should be recognized as a Parosteal Osteosarcoma. It's another example. So Parosteal Osteosarcomas usually occur in the 20 to 40 age group. They usually grow for a prolonged period of time. The most common site is the posterior distal femur. And patients may often complain of a prolonged period of a decreased range of motion of the knee. They're usually painless until they reach a large size. They may grow backward into the medullary canal or may even differentiate or become high grade in nature. When they do this, they have a worse prognosis and a higher metastatic rate. Tumors that actually penetrate backward into the medullary canal tend to have also high-grade areas and mixed with them. But for a standard Parosteal Osteosarcoma, which is a low-grade tumor, most of them present as stage 1A tumors, meaning growing from the surface of the bone, and they have not back invaded into the bone. Low grade in nature, slow growing, and they're treated with surgical resection alone, wide resection and reconstruction. Rarely, they rarely would you have to perform an amputation unless it was a massive tumor, and or it was encasing the neurovascular structures, or fungating, or somehow there was a lot of contamination of the thigh or of the area where it was growing from. And the only indication for chemotherapy would be if there was a dedifferentiated component or if there were high-grade areas of the tumor, which gives it a higher metastatic potential. The prognosis is for pure Parosteal Osteosarcoma, 90% cure rate or 90% 5-year survival rate, and they're very slow to metastasize. So chemotherapy is not indicated in the treatment, and neither is radiation. This is case number 19. This is a 22-year-old male, 6 months of pain in the right knee and hypoesthesia in the right foot. This is a plain radiograph, AP of the knee, and you see over here a tumor developing from the proximal fibula. The tumor is permeative in nature. It's extended into the soft tissues. There's a periosteal reaction around it. And it looks to me, that it has sclerosis or some fluffy white ossification associated with it. This, to me, has a malignant appearance, and if you were able to identify ossification in the soft tissue component or in the medullary canal, you'd be very concerned that this was an osteosarcoma. Although an unusual area for an osteosarcoma, it certainly is a plausible area. It is a metaphyseal area in a relatively young patient. Osteosarcomas more commonly occur in the distal femur, proximal tibia, and proximal humerus, but certainly can arise from the proximal fibula, or really any place in the body. 90% of osteosarcomas arise from the metaphysis and 10% from the diaphysis. But this would be very concerning for me for it to be a malignancy, and it's permeative in nature. It has an aggressive appearing periosteal reaction, and it appears to be producing bone. In a plain radiograph, you have a permeative lesion arising from the proximal fibula. There may have been a pathologic fracture. You seem to have a periosteal reaction or soft tissue component of the tumor, and there appears to be mineralization within this tumor, or ossification. MRI gives you a better idea of the soft tissue spread of the tumor, and given the x-rays and the MRI appearance, this tumor has a malignant appearance to it. Again, T1 and T2 weighted MRI. And this is what the pathology showed, what the biopsy showed. So you see a hypercellular tumor. The cells are packed on top of each other. There's hyperchromatic nuclei. There's bizarre large nuclei, lots of pleomorphism, probably mitotic figures. And then you see this cloud, this pink staining material deposited in between all the cells. This is a high power view showing you these very heavily pycnotic nuclei and this pink staining material being laid down by these cells. This pink staining material is immature bone production or woven bone or osteoid. So you have, putting the x-rays, you have a malignant appearing radiographic appearance of the tumor rising from the fibula. You have ossification, and you have a biopsy sample that shows a malignant appearing tumor producing bone. So this is a conventional osteosarcoma. It would be treated with chemotherapy, followed by surgical resection, followed by more chemotherapy. Again, conventional high-grade osteosarcoma, which is most common in the 10 to 20 age group. The fibula is actually a very unusual site for an osteosarcoma, although it can occur there. It arises from the metaphysis. Most present as extraosseous tumors without metastases or stage 2B tumors. The most common sites of origin are the distal femur, proximal tibia, and proximal humerus in that order. And they're treated with preoperative chemotherapy, surgical resection, and postoperative chemotherapy. The chemotherapy agents that are utilized are adriamycin, which is also called doxorubicin. That agent may demonstrate cardiotoxicity, cisplatin, and high-dose methotrexate. Next case is case 20. This is a 32-year-old male who had severe pain in his right foot, especially at night, for the last 7 months. So looking at the radiographs, I think I see some sclerotic changes in the calcaneus in this location, but nothing really specific. Just some sclerotic changes in these densely white areas. Again, nothing specific on these x-rays, not even on the, perhaps on the AP view I can't see much. I don't really notice too much in the calcaneus on these, on the talus on these studies. Here's a CAT scan which shows that there's a lesion in the calcaneus. The talus looks fine. There's a small lesion. It's very well circumscribed in nature. It has some surrounding sclerosis around it, and it has some mineralization deposited within it. So it has a benign appearance, so one would be thinking that this is a benign tumor. And with the mineralization, immediately you're thinking that this is either a bone-forming tumor, a cartilage-forming tumor, or possibly an infection that has sequestrum within it. And I think the differential diagnosis here, especially given the night pain, would be an osteoid osteoma, an osteoblastoma, which is a larger version of an osteoid osteoma, but tends to have a different pain pattern. Infection and eosinophilic granuloma would be the main entities in the differential diagnosis. This CAT scan appearance is extremely characteristic of an osteoid osteoma. Shows you the MRI where you have the lesion in the calcaneus, and the T2 weighted image where there's an extensive amount of edema in the calcaneus. Osteoid osteomas are usually associated with an extensive amount of peritumoral edema that can be identified on the T2 weighted MRI image. Again, the MRI doesn't add much in terms of the diagnosis, but you can see the lesion in the calcaneus with peritumoral edema surrounding it. And this is showing you the histology. The lesion was removed or was sampled, and this is the histology, and you see almost what appears to be a fibroblastic vascularized type of tumor. There's a lot of vascularized tissue here with an extensive interlacing network of trabeculae of woven bone with osteoblasts nicely lining the woven bone. These osteoblasts are nicely lined up along this bone, which helps differentiate this from an osteosarcoma. In osteosarcomas, you don't get osteoblastic rimming, or you don't get the osteoblasts not lined up nicely along the trabeculae trying to replicate normal bone. Remember, as things are benign or less anaplastic, they tend to replicate more normal structures. So this is very much consistent with a nidus. Again, very much consistent with the nidus of an osteoid osteoma. Here's the reactive sclerotic bone around it. Here's the nidus. Here's all the interlacing and interconnecting trabeculae. And then on the high power view, you see the osteoblast rimming the bone and lining up nicely along the surface of the trabeculae, and fibrovascularized tissue with these blood vessels within it. Okay, the diagnosis is an osteoid osteoma. Osteoid osteomas can really arise in any bone, in any location within the bone. They are more common in the femur, and particularly the proximal femur, and they can occur in the metaphysis, the diaphysis, or the epiphysis. They're very irritating to the bone, result in an extensive amount of peritumoral edema that can be identified on an MRI. They are often associated with a benign appearing periosteal reaction and intense surrounding sclerosis. When they occur in the epiphysis, they can be misconstrued as a rheumatological process because they can cause an intense joint effusion. They can also occur in the spine and present as a painful scoliosis. Bone scan can be very useful in the workup for a suspected osteoid osteoma. Osteoid osteomas produce pain by producing prostaglandin E2. NSAIDs and aspirin turn off the prostaglandin E2 production and hence eradicate the pain. So one of the characteristics of an osteoid osteoma is pain worse at night that's made almost immediately better by taking an NSAID or an aspirin. Osteoid osteomas and osteoblastomas look identical histologically. Osteoblastomas are benign aggressive tumors and are usually greater than 2 centimeters in size. Osteoid osteomas usually only grow to 2 centimeters in size and not beyond that. And they may only be a few millimeters in size and be exquisitely painful and very difficult to detect. Osteoblastomas will continue to grow and destroy bone and are treated differently. They also have a different pain pattern and do not respond to NSAIDs as readily as an osteoid osteoma. The treatment for osteoid osteomas nowadays is radiofrequency ablation. Patients can be treated with chronic NSAIDs. However, this can result in gastritis, kidney problems, and it may take years for an osteoid osteoma to burn out. And in the meantime, the child is in pain, has difficulty with school, difficulty playing, and difficulty getting sleep. So really the mainstay of treatment nowadays is radiofrequency ablation, and it's over 90% effective in eradicating the osteoid osteoma with less than 10% of a risk of recurrence. Okay, I want to thank you for listening to Part B of our Unknown Tumor lectures. Hopefully you've learned a lot from this lecture. I think that it represents a nice review for your boards or your OITE exam. Please look at Part A and also Part C and any other future parts that future lectures that we post on unknowns. I think it's a very useful exercise in going through this and deciphering the differential diagnosis and then looking at the biopsy specimen and figuring out the treatment or learning the treatments for the various tumors. For more information on musculoskeletal tumors, please visit my website at www.tumorsurgery.org. Thank you very much.